Hi, it's Dr. Toker, your friendly neighborhood colorectal surgeon. We're going to discuss today a very bizarre conversation about fecal incontinence. What is it? And what can we do about it? So most people don't like talking about this topic simply because it's sort of a social embarrassment issue. It's present in probably 2% of the population. I would say it's more common in females than males. But it can happen in either occasion. It's not necessarily gender specific. And basically incontinence is just simply you, you no longer have control of bowel function. In my practice, we're dealing with fecal incontinence. It's present in probably 2% of the adult population, and there's a reason there's an entire section in the grocery store for undergarments that protect your clothes. And so it is a common problem that very few people talk about, and they're hesitant to even bring it up with their primary care doctor, and perhaps the primary care doctor does not know how to proceed other than protect their clothes and change them frequently, which is not exactly an acceptable option. The complications that people can experience because of incontinence, aside from the social problem, is skin breakdown, and the chronic wounds that we see in the older population, particularly in nursing homes and whatnot, a lot of times are due to incontinence of either urine or stool. And so it is actually an important problem to deal with. And so to describe kind of why does it happen, there are several factors that go into the body's ability to hold on to stool. It's actually a pretty remarkable feat, to be honest with you. You don't come out of the womb capable of controlling your own bowel or bladder, which is why they have diapers for little children. It is a learned pathway that requires normal musculature and normal nerves. But if you have a defect in muscles or nerves, you can still kind of relearn how to control things. In the most basic of biologic terms, 3 things have to happen to maintain your continence. Number 1, you have to be able to feel that there's something present in the rectum. Number 2, you have to be able to have a complete reflex arc that connects that sensation to, at a minimum, your spinal cord, but preferably to your brain, that tells your body to hold on to that stuff in your rectum. And then number 3, that needs to spark a muscular response that holds on to the contents of the rectum. And I hope everyone's enjoying my high-tech slideshow, but basically this is a rectum, and I'm gonna try to film and point at the same time. So the rectum is like a V-shaped funnel. There are internal and external muscles present. Let me find a pen so my big fat finger's not in the way. Whoop. So, and they form a circle around the rectum like a donut. So there's an internal muscle and an external muscle, and then there's a levator floor puborectalis muscle. The internal muscle, you have no control over. It is, oh, whoops, there's my pen. I'm sorry, high tech. The internal muscle is always contracted. It always has tone until stool fills this area. And there's a reflex here when this rectum distends because there's poop there. That muscle, by definition, is going to relax. You have no control over that whatsoever. This is why babies and even people who are paralyzed are able to poop. Rectum fills with poop, muscle relaxes, poop leaves the body. Now, what gets your baby out of diapers and what keeps you out of diapers is actually a second reflex arc that goes from rectum to internal muscle. It says, I'm about to relax, sends a reflex to your spinal cord and then up to your brain that says, if this is not a good time to have a poopy kind of a moment, then you should probably squeeze this external muscle. And this is what you physically have control over. This external muscle will squeeze basically on demand, but you can only squeeze that muscle for, I don't know, 10, 15 seconds. Have you ever tried squeezing this muscle? I'm an old woman, so maybe that number is higher, but still, I'm just saying, it's hard to hold on to this poop. You can only squeeze it for a finite amount of time. So if this reflex inside the rectum overwhelms the length of time and the strength of this external muscle, you're going to poop on yourself anyway, even though you have sensation and even though you have the reflex. If you don't have the muscular strength, well, you're going to have an accident. So there are several things that can leak out of your hiney without your permission. The first is air. The next is liquid stool, followed by solid stool. And these are all considered forms of incontinence. Now, some of my patients will come to me because there's some mucus leaking from their bottom from a hemorrhoid or a fissure or a fistula, and that's actually not considered incontinence. And so one of the reasons to have an evaluation by someone like me is to determine the difference, as the treatment is quite different. Okay, so who's at risk for getting incontinence? The majority of my patients with incontinence are female because childbirth, delivery of children, is a pretty big risk factor. Why? Because you can injure the muscle, you can injure the nerves. And so, as I had mentioned in my little cartoon, you've got to have nerves, that sensation, nerves that complete a reflex arc to your brain, and then you've got to have muscular strength to contract voluntarily in order to avoid incontinence. So if you've had a baby and an injury to the muscle from an episiotomy or a tear, you've already got a muscle problem. Oftentimes, the weight of the baby, stretching of the pelvic floor will stretch nerves and cause nerve injury. Add to that time, maybe a back injury in your lifetime or some such thing as that, and now you've got the perfect setup in your 50s, 60s, and beyond for incontinence. So who else gets incontinence? People with normal anatomy who have uncontrollable diarrhea, people who've had prior surgery that either interferes with the muscles or this reflex arc, people who have neurologic problems, some people with metabolic problems such as diabetes. Anything that can interfere with this neurologic arc and the musculature can lead to a breakage of this link between your bottom and your brain. So how do we treat that is the next most important question, right? So the first thing we do is we have to evaluate you. Are you somebody who has a muscle injury? Are you somebody who has a nerve injury? Do you have an intestinal infection or an inflammatory bowel disease, which is causing the stool change? And so sometimes we can do very simple things to improve your continence, such as change the stool consistency. Maybe you just, with time, those muscles have gotten weak and you would benefit from physical therapy to reconnect. And I know that sounds crazy, but sometimes you just have to reconnect your brain to your butt. It can just happen over years. You just sort of take it for granted. And then the next thing you know, they're disconnected. And so to reconnect that, there's certain exercises, what we call Kegel exercises. And sometimes people will need a professional physical therapist to kind of guide them through exercises. So medications or dietary changes to change stool consistency, physical changes that would occur with exercises, all can improve continence. And so if we do those two things and you get better, then there's really nothing for me to do. However, patients who have had more than 6 months of incontinence, so in other words, chronic problem, who've tried the medications, who've tried dietary changes, who've tried physical exercises like the Kegel exercises, but still struggle, and by struggle we mean at least twice a week with incontinence. And mind you, incontinence does not have to be you leak something out into your clothes. I've got a lot of patients who are homebound because if they get too far from a bathroom, then they would be incontinent. And they don't want to wear a diaper or admit that they're incontinent, so they stay home. Or maybe they only shop at stores where they know where the bathroom is. Or maybe at work, they make sure their office is right next to a restroom. And I've had some patients who have had to leave their line of work because their employer would not let them sit close to the restroom or take frequent restroom breaks. And the patient doesn't want to have episodes of incontinence in a public environment. Okay, so if your life is altered because of that sort of bathroom confinement from urgency, that's incontinence, whether you've bought a diaper or not. Okay, so that's what I'm talking about as far as twice a week. So if twice a week you think to yourself, oh my God, thank God my bathroom was 10 feet away because I wouldn't have made it otherwise, then that's incontinence. And those patients need to do the rundown. Physical exam, let's look at it, make sure there's not some disaster brewing. If your anatomy is reasonably normal, let's do some medications to slow down the stool. Let's do some exercises to improve your muscular strength, your reflex strength. And if those things fail, then we talk about intervening. When I did my training, and I can't believe it's been 18 years since I finished my fellowship, but back then, the only option, the best option, was a muscular reconstructive surgery. So patients who had a muscular defect from either surgery or delivering a baby were the best candidates for surgery for incontinence. Because broken muscle, bring it together mechanically, we can make that kind of work better. Patients had a good outcome from that, but it usually was quite short-lived because it takes more than a normal muscle to make a patient continent. There were other things that we had. We had artificial sphincters, again, to occlude the muscle, and then it was like a little balloon. There was that. There was a little one with magnets that did basically the same thing. There was something called a Fecal procedure where we would try to scar down the muscle. Everything was designed to occlude the anal opening. But again, it takes more than putting a cork in it to make you continent. The more obstructive you make the rectum, the more patients have to strain to empty the rectum, the more you're damaging the nerves. And then as it turns out, neurologic input, in particular sensation, is probably the most important aspect of continence. So if you're a young person with severe diarrhea, you can be incontinent for a week's period of time while you're experiencing this diarrhea because there's not enough time between sensation from your bottom to your brain. Some people, this is happening to them all the time, whether they have diarrhea or not. There's not enough time between when they have sensation and when it gets to their brain and when it gets back to their muscle and to complete that reflex art and allow them to either make it to the restroom or contract a muscle. For this reason, this observational reason, one of the mainstays of treatment now for incontinence, but and we use it for urinary incontinence as well as stool incontinence. For fecal incontinence, this procedure is effective probably 90 to 95% of the time. It's very uncommon where it does not help people who fall into that 6 months worth of time of incontinence, more than 2 episodes a week. They've tried the medicines, they've tried the exercises, and now we're stuck. Those people have a 90 to 95% chance of improving with a particular procedure called a neural modulation device. And in particular, we're talking about a sacral neural modulation device. In other words, a nerve stimulating device. It looks like a pacemaker that goes into the third sacral nerve of the pelvis. There are 3 nerves that exit the sacral spine to form the nerve that controls both fecal and urinary continence. 2 of those nerves have a lot of other muscular components, but that third sacral nerve tends to just affect the rectum, and so therefore, in the bladder. And so for the reason of lack of side effects, basically, for lack of better words, we only need to stimulate that third sacral nerve. And interestingly, and this is how you know you're beautifully and wonderfully made, you really only need 1 nerve to make this work. You don't need two. There's lots of redundancies built into the human body, which is amazing. So you can have a lot of damage and still make that sucker work. And so one nerve is all you need. And so we do something called the sacral neuromodulating procedure. And in a separate video, I'll explain exactly kind of what's involved with that and how to prepare for it. But that's called an interstim. The main maker of this device is called Medtronic's. There's a link to my website to Medtronic's. There's a competitor on the market called Axonics. It's kind of same, different. Sacral neuromodulation, but a slightly different technology and approach to stimulating the nerve. And I don't have their link yet. They're pretty new. But I do perform both of those procedures. So for patients who, out of curiosity, are watching this video, if you have had more than 6 months worth of incontinence, you've kind of done everything, you don't know where else to go, come see me and I'll take a look at you. Maybe there's something I can do mechanically for you, but if not, don't lose hope. You don't have to live in a diaper. Our goal for you is to improve your continence with a nerve stimulating device. And if that nerve stimulating device improves your quality of life by 50%, we consider that a win. And you should consider that. Separate yourself from the bathroom. Get out of your house. And literally, I have sent women back to the golf course, back to hiking, out on the mountaintops somewhere. You want to be back to life. And that's what these devices allow you to do. It's not about how it looks. It's about how you personally are functioning. And that's what we aim to improve.